synthesis, the how it's regulated, the production of thyroid hormone, how it is regulated by the hypothalamic pituitary thyroid axis, what are the components of thyroid function tests, and then how to interpret uh, thyroid function tests, and how to have a protocol or testing strategies given a particular situation. Which one should you request for? Let's start off with thyroid hormone synthesis. So, general anatomy of the thyroid gland. So, it's a butterfly shape in the lower anterior mid portion of our neck. And to zoom in, this is a cartoon of the cut portion of the thyroid gland. So, each thyroid follicle is the functional unit of the thyroid gland. And each follicular cells are capable of producing T4 and T3. Then you have your parafollicular cells or the T cells producing calcitonin. But for today, we're going to focus on the production of thyroxine and triiodothyroxine. So this is the basal side or the capillary side. On the right side is the apical side of a thyroid follicle. And iodine is going to be trapped, transported from our diet. That's why it's important to have iodine in the diet. And eventually, the iodine will be organified through the help of uh, thyroid peroxidase and with hydrogen peroxide, which is going to be incorporated into the thyroglobulin. So what happens is within the thyroglobulin, you're going to have your tyrosine, and each of those tyrosine can either be iodinated by one iodine or two iodine. And the coupling of two diiodotyrosine will give you T4, and the coupling of one MIT or monoiodotyrosine with one diiodotyrosine will give you T3. And once once stored in the thyroglobulin within the colloid, as needed, the cells will take a bite of the colloid where the thyroid hormone is, and it's going to be lysed by the lysosome, and it will release T4 and T3 to the circulation, and also some of the DIT and MIT will be deiodinated, and then will also join the pool of iodine from the circulation. So once released into the circulation, majority of the T4 will be deiodinated to T3. So we'll talk about how much the thyroid gland can produce T4 and T3, and how much of the T3 comes from deiodination of T4 in the liver and kidneys. So these are very simplified steps of how thyroid hormone is synthesized. So let's talk about how thyroid hormone secretion or release is regulated. Very simple. So TRH, or the thyroid releasing hormone, or thyrotropin releasing hormone, from the hypothalamus will stimulate the TSH, the anterior pituitary TSH, or what we call thyroid stimulating hormone, or thyrotropin, to be released from the anterior pituitary. It will then go into the circulation and reach the thyroid gland. There are receptors within the thyroid gland for the TSH. And once stimulated, the thyroid gland will then initiate the whole process of pinocytosis, taking a bite of the preformed thyroid hormone within the thyroglobulin, and then lyse it and release a T4 and T3. Once the T4 and T3 are in the circulation, then it will reach both the hypothalamus and the anterior pituitary, where there are receptors for thyroid hormone. So once they sense the amount of thyroid hormone, and if there are deficiencies, the whole axis will be activated. And you have excess, then TSH and TRH release will be suppressed. So that's how we regulate T4 and T3 in our circulation. It's important to know that only the free T4 and the free T3 are active. So what do we mean by free T4 and free T3? Both T4 and T3 are highly protein bound. We'll talk about this in a bit further. And it's only the free unbound portion of the thyroid hormone that are functional in the periphery or biologically active. And it's only the free T4 and free T3 that can exert negative feedback to the anterior pituitary. This is important to know as we interpret thyroid function tests later. So let's talk about each possible test that one can request for. TRH, secreted by the hypothalamus, it acts to stimulate the anterior pituitary TSH. There are no significant peripheral tissue effects. There are some, but they are not clinically significant. They are not available as a test, so never order TRH, and that's why we don't order them. In research setup, the TRH can be measured, but not for clinical use. It responds to negative feedback by both FT4 and FT3. TSH, on the other hand, otherwise known as thyrotropin, is secreted by the anterior pituitary, stimulates thyroid follicular cells to produce T4 and T3. No significant peripheral tissue effects, at least clinically, and it responds also to negative feedback by FT4 and FT3. T4, T3 from the thyroid follicles is secreted, and then it's only the free T4 and free T3 that are active, biological active peripherally. So we'll talk about these in a bit. Very important. So we're going to talk about the two hormones produced by the thyroid gland, T4 and T3. Okay, so it's important to know that the thyroid gland produces 100% of your T4, but only 20% of your T3. 80% of T3 in the circulation is from T4 deiodination in the liver and the kidneys. And this is important. And why do we need to know this? This is the reason why, if a person is hypothyroid for whatever reason, whether it's autoimmune thyroid disease or thyroidectomy or radioactive iodine, once they're hypothyroid, one need not give T3 for great majority of patients. So all the thyroid hormone preparation that you know of in the market, at least in the Philippines, are purely T4 because anyway, 80% of your T3, the more active hormone, is from the iodination of T4 by the liver and the kidney. So we need not replace T3 in patients who are hypothyroid. The other reason that you need to know this is when we talk about hyper or thyrotoxicosis later, okay, there are two general types. It's either leakage of thyroid hormone or new production, what we call hyperthyroidism. In hyperthyroidism, such as Graves' disease, there is a preferential production of T3. And if you're leaking only, like for example, subacute thyroiditis or painless thyroiditis, generally the amount of T3 is not that high because the stored thyroid hormone from your thyroid gland is largely T4. So it's one of the way how we differentiate whether the patient is overproducing new thyroid hormone because there's preferential production of T3 versus the patient is just leaking thyroid hormone because there's some inflammation going on. So you have a lot of T4, but not too much of increase in T3 if you're leaking. And the importance of 7 days half-life of T4. 7 days half-life, by principle, you need about 4 to 5 half-lives to consume a drug. And this is the reason why, because of the long half-life of T4, 7 days, after total thyroidectomy, one need not worry about hypothyroidism within 7 or even 14 days. Generally, there are, as long as the patient entered total thyroid, the procedure, euthyroid, the circulating thyroid hormone in your blood will keep you euthyroid for at least 1 to 2 weeks. So this is important to know that one need not be concerned about thyroid hormone being lacking after total thyroidectomy. And how about patients who are hypothyroid and on exogenous thyroid hormone? Exogenous thyroid hormone, same 7 day half-life. So, for example, you have a patient who's hypothyroid and they are on maintenance thyroid hormone and they underwent a colon surgery, for example, for which are going to be NPO for about 4 to 5 days and they won't be able to take their thyroid hormone pill. Again, in those situations, you need not worry about patient becoming hypothyroid because of the long 7 day half-life of T4. And they are both highly protein bound. We'll come back to this, big inactive, and only less than 1% of T4 and T3 are active. T3 is really the main thyroid hormone. It is the more active one, and T4 needs to be activated or deiodinated to the more active T3 before it can exert its action and negative feedback. So these are basic knowledge that helps us interpret or at least understand the situation, any clinical situation the patient might be in. So let's talk about what are the components of thyroid function test. Let's start off. We talk about total T4 versus free T4, total T3 versus free T3. So we said earlier in the prior slide that less than 1% of both T4 and T3 are in its active state. Uh, Once they are bound to a protein, there are multiple proteins by which T4 can bound to or bind to, um, and while in a bound state, they are inactive. Therefore, they cannot exert a negative feedback and they cannot exert peripheral action. But they're there as a pool just in case you need thyroid hormone very quickly. And some thyroid hormone, the bound thyroid hormone, can be released to be active before the thyroid gland will release them. So the question is, there are four possibilities that you can request for here: T4, total T4, or free T4, um, total T3 or free T3. Do you need to request all of them? Generally, the answer is no. So let's talk about four different combinations. So if one requests for free T4 or free T3, what you're requesting for is the less than 1% active hormone. But if you request total hormone, it's a combination of the active, less than 1%, and the more than 99% bound, inactive thyroid hormone. So all these four represents euthyroidism. For as long as free T4 and free T3 are within normal, we really don't care about how much hormone are bound because they are inactive. They don't have peripheral action and they don't exert negative feedback. It's important to know this because there are situations whereby the total T4 is elevated, like the third line here, and the TSH will not be suppressed because the free hormone that's controlling or that's regulating your hypothalamus and pituitary is still normal. And the opposite might be true. There are situations whereby the binding protein might be low, and if you request for total T4, and it's low, the TSH may not move for as long as the free hormone are within normal range. Okay, so one needs to know the common conditions by which the binding protein might go up. Two, that one can really think of is oral contraceptives and pregnancy. So during situations like this, in normal people, if a person takes oral contraceptive estrogen or the increase in estrogen is due to pregnancy, what happens is the binding protein goes up. In people with normal axis and normal thyroid, it's not a problem because as the carrier protein takes up the free hormone, the pituitary will sense the drop in free hormone. So the whole axis will be activated and thyroid hormone will be produced to maintain the free T4 in its normal state. However, a person who's taking thyroid hormone from outside, okay, even if the axis goes up, the axis, remember, the thyroid gland is not working. So therefore, during pregnancy or intake of estrogen, patients who are hypothyroid on exogenous thyroid hormone, you will have to increase the thyroid hormone tablet for them while they are on estrogen, OCPs, and while they're pregnant. And just remember, once they deliver, the binding protein will go down again. So therefore, you need to go to the pre-pregnancy thyroid hormone dose for these patients. How about what are drugs and conditions that will drop? So if you have estrogen that will increase TBG, glucocorticoids and androgens, and commonly furosemide, can decrease binding protein. But again, if the axis and the thyroid gland is working properly, once the thyroid hormones are released, then the free hormones will exert a negative feedback to the pituitary. So therefore, there's really no problem if you're taking steroids and androgen if all the axis is working properly because the body can adapt. So these are the possible hormones that you can request for: T4, T3, FT4, and FT3. Generally, now the preferred test that you have to ask for is either free T4 or free T3. And rarely do we request for total T4 and T3 so that we don't have to deal with whether the patient have a binding protein problem. However, in the provinces, where free T4 and free T3, or some hospitals where free T4 and free T3 are not available, then total T4 and total T3s are equally good as long as you're not dealing with those binding protein problems that we talked about earlier. So uh, just remember that there are situations, medications, diseases that can either increase your carrier protein or drop them, making the T4 and T3 go up or down without moving the TSH. Okay? And for TSH, the normal value is generally zero point 0.3 up to 4. And let me talk about the right lower portion. TSH has been developed very well over the years that the lower limits of sensitivity is going down lower and lower. And in fact, there are fourth generation TSH nowadays. What's the importance of this? Look at the lower limits of TSH. It's zero point 0.3 to 4. If one uses the first generation, what the lab will just tell you is anything below 1 will be reported as less than 1. So you really wouldn't know whether the patient is normal or not. If you use a second generation, zero point 0.1, yes, it can differentiate zero point 0.1, zero point 0.2, zero point 0.3, but we need the suppression of TSH, the degree of suppression of TSH during hyperthyroidism that helps us differentiate or define the extent or the severity of the hyperthyroidism of the patient. So generally nowadays, most of the labs, I'm sure in St. Luke's and most of the tertiary centers are using third generation. The lower limit of zero point zero 0.01, so meaning they will report anything lower than this as less than 1, but defining zero point zero 0.01 versus zero point 0.1 makes a difference in terms of defining how severe the patient's hyperthyroidism might be. So that's why generally we said either third or fourth generation TSH, what the laboratory should provide. But generally, you don't need to worry about this. Most of the labs in bigger hospitals are capable of using third or fourth generation TSH. And generally, one needs to remember that the normal values for this thyroid function are different for for pregnant rather. And the recommendation is to establish your local method wise. One needs to do a study. We have one in the Philippines done by PGH, but their methodology might be different from St. Luke's. So generally, the recommendation would be St. Luke's will have to define their own normal limits for thyroid function during pregnancy. So let's talk about interpretation of thyroid function tests. So remember this negative feedback. Generally, the rule of negative feedback in regulation of most of hormones in the body. But when it comes to thyroid regulation by the HPT axis, one can see that the relationship as an inverse log linear. We know it's inverse as T4 goes up, TSH will go down, or vice versa, as T4 and T3 goes down, TSH should go up. We know it's inverse, but this negative feedback is so sensitive that it's inverse log linear, that for every 1 point increase in T4, there's going to be 100-fold drop in TSH. Those, so there's a really wide swing of the TSH for a tiny change in T4, making TSH a very sensitive test. So one can look at, if you understand this inverse log linear, going from right to left, okay, free T4, as it goes down, one expects 100-fold drop in TSH, making it really sensitive. But if you cannot understand this particular inverse log linear relationship, I created a cartoon that might help you understand. So you have your FT4 and FT3 on the left side. Remember, it's only the free hormone that regulates uh, negative feedback to the TSH, and TSH on the right side. So the blue bars represent the normal range of FT4, FT3, and the normal range of TSH. So one can see that the TSO inverse linear is not in the middle. It's very near T4. So one can imagine that tiny changes in T4 and T3 will cause a wide swing in TSH. That, for this example, is euthyroid. In the neck, the patient is still euthyroid. Both of them are within normal range. But as one T4, T3 goes down to the lower limits of normal, there's a point in time whereby T4, T3 are in the lower limits of normal, but TSH is already above. The pituitary is already sensing the deficiency of thyroid hormone. And this is what we call subclinical hypothyroidism or mild hypothyroidism. As hypothyroidism becomes worse, one becomes overtly hypothyroid, TSH will go really high and with low T4 and T3. So once you start the patient on thyroid hormone because of primary hypothyroidism, this is what's going to happen. The first thing that will normalize is T4. Okay, sorry about that. So primary hypothyroidism. Once you start the patient on thyroid hormone, the FT4 and FT3 will improve, and then eventually, at some point in time, FT4 and FT3 will be normal, yet the TSH is still slightly above normal because you have to, because of its long half-life, it takes about 5 to 6 weeks for the T4, T3 to steady up. And while the FT4, FT3 are slowly going up, TSH will slowly come down. So TSH is the first to become abnormal, but is the last to recover during treatment. So how about going to the opposite side? So as T4, T3 goes up, TSH will widely swing down. So there's a point in time of mild hyperthyroidism where T4, T3 are still in the upper limits of normal and TSH is already suppressed. First to become abnormal, okay? And then as one become overtly more hyperthyroid, TSH will go down to near zero. Once you treat the hyperthyroidism, then the first to recover will be T4 and T3. For as long as the pituitary is still sensing some excess of thyroid hormone, TSH will remain suppressed. And this is the reason why during the treatment of Graves' disease, generally, I do not bother checking the I do not bother checking the TSH rather. I will just follow the T4 and T3, and I will wait for FT4 and FT3 to normalize before I'll start checking TSH. For as long as one of the two, FT4, FT3, are still above normal, we will already know that the TSH will remain to be suppressed. So there's no point checking the TSH in the early phase of treatment of hyperthyroidism. But eventually, it's the pituitary that you have to please. So as FT4, FT3 comes down further, TSH, after some time of normal T4, T3, the TSH will then normalize. So generally, as long as the HPT axis is intact, there's nothing wrong with your pituitary. These are the five most common combination that you're gonna see. Okay. So in the middle, euthyroidism, both T4, T3, and TSH are all going to be normal. But in the early phases of mild hypothyroidism, TSH will be the one to become abnormal. So this is how we define what subclinical hyperthyroidism is. FT4, FT3 are both normal. TSH suppressed, meaning the pituitary is already sensing some excess thyroid hormone, and then eventually they become overtly thyrotoxic. The opposite end, the pituitary is already sensing some deficiency, but the T4, T3 are probably in the lower limits of normal, but the pituitary senses it, so TSH goes up until the patient becomes overtly hypothyroid. So these are the five combinations that you really need to worry about or think about in most patients because most of the patients, their HPT axis will be intact. So what can go wrong with thyroid dysfunction? So you either have too much, which is thyrotoxicosis, or too little, which is hypothyroidism. And 95% of the times, it will follow the seesaw because 95%, more than 95% of the times, it's a thyroid gland that's diseased. Pituitary disease is rare. For example, TSH producing a tumor to cause thyrotoxicosis or hyperthyroidism is extremely, extremely rare. Okay, so in my 20 years of practice, I've never diagnosed on my own. I followed the couple, and it's really rare. And if you see a picture of TSH producing tumor in the thyroid function test, which we're going to talk about in a bit, you probably should think about a lab error. Okay. Secondary hypothyroidism is a bit more common than TSH producing tumor, but secondary hypothyroidism compared to primary hyperthyroidism is really far, far different. It's not as common. So we need to define whether the excess or deficiency is largely thyroid or is it pituitary problem. So once you request TSH being the best screening test, then you proceed to do 3T4, okay? Then there are 9 possible combinations. So you either have a low TSH normal, TSH or high, with the combination of low, normal, or high 3T4. Therefore, 9 possible combinations. So let's talk about how to interpret them. So what if you have low TSH? The one that really follows the seesaw here, if you have a high T4. So that's the end of it. You have excess thyroid hormone causing a suppressed TSH. So you have primary thyroid toxicosis. It could be Graves' disease, new production or leakage from subacute or painless thyroiditis, or it could be from outside. Let's talk the middle column. So when do you have low TSH but normal T4? So we talk about this in the earliest form of excess thyroid hormone. The TSH will be already suppressed, and you have T4 still in the normal range. And we also talk about once you start treatment from the right side, the high T4, Graves' disease. Once you start treating Graves' disease here on the right side, in the early phases, T4, T3 will start to normalize, but TSH will be the last one to normalize. So one can also see this combination in the early phase of treatment of hyperthyroidism. And the other one differential diagnosis is T3 toxicosis. In about 5% of Graves' disease, the T4 does not budge. It doesn't go up. It's only the T3, isolated T3 toxicosis. So before one defines a mild hyperthyroidism or subclinical hyperthyroidism, you have to make sure that the T3 is not elevated. And if it's elevated with a normal T4 and low TSH, it is the high T3 causing the suppression of the TSH. So we call this T3 toxicosis. And on the left side, if you have low TSH and low FT4, this is not appropriate. A low T4, if the pituitary is intact, the TSH should go really, really high. If it did not, then you think about secondary or central hypothyroidism. Okay, let's move on to the next TSH. What if the TSH is normal? The best, easiest one to interpret here is you have a normal T4, then therefore the patient is normal. If on the right side, if you have free T4 that's elevated, supposedly TSH is down, this situation is somebody who's hypothyroid, who on the day of getting a thyroid blood test, the dose might be right, but the patient just popped the pill, and the thyroid hormone might just be a little bit high uh, with a normal TSH. On the left side, free T4 is low, but TSH remains normal. This is inappropriate. The appropriate response of a low T4 should be a high TSH. In the in subtler or milder secondary hypothyroidism, you can see this picture: a low T4 with an inappropriately normal TSH. Let's go to the last. A high TSH, the easiest one to interpret is the one that follows seesaw. If you have low T4 with high TSH, it's easy. This is primary hypothyroidism. You just have to look for what's causing it from diet, asking them from diet, whether they underwent thyroidectomy, radioactive iodine, or they may have a firm thyroid, Hashimoto's thyroiditis, autoimmune destruction of thyroid hormone. So worldwide, the most common cause of hypothyroidism remains to be iodine deficiency, followed by in countries, developed countries, and the number one cause will be Hashimoto's thyroiditis. Philippines is no longer considered an iodine deficient country. There are still pockets, but the number one cause of hypothyroidism right now in the Philippines is Hashimoto's thyroiditis. And of course, the history of radioactive iodine thyroidectomy will tell you the etiology. What if the patient has a normal T4 but a high TSH? Maybe the pituitary is already sensing early mild hypothyroidism. That's why TSH is already elevated, trying to make the thyroid gland work a bit harder. Or in the early phase of treatment of primary hypothyroidism, on the left side, okay, you start and you did not work, you did not wait for the 6 weeks of stabilization, stabilization of the level of T4, then one might see a high TSH with normal T4. Okay. Or if you did not give enough thyroid hormone, the patient is suboptimally treated, one can still, then this is how you determine that despite waiting for 6 weeks before you get the thyroid function test, this is how you know that you need to increase the dose of the thyroid hormone because the TSH or the pituitary is still not happy. What if you have both high? The appropriate response of a high free T4 is a low TSH. If it's normal or it's high, then it's you say it might be a TSH producing adenoma. But again, this is very, very rare. Then if you see this picture, I would really strongly doubt it. But I'll repeat the thyroid function test. Or you have generalized resistance to thyroid hormone. So therefore, the hormones including the pituitary, is not sensing the thyroid hormone. So it will try to increase the TSH, and the T4 naturally will go up because of the high TSH. So these are the common possible nine combinations. So which ones to request for? The testing strategies. Let's talk about the testing strategies. If your suspicion for thyroid dysfunction is quite low. Let's say out of the picture, the patient, everything is perfect. They just have a nodule or a goiter. But everything asked them from weight, cold heat intolerance, menstrual cycle, they absolutely don't have any symptoms. Then all you need to do is TSH alone. Okay? Because TSH will be the first to become abnormal. There's no point making the patient spend money on T4 and T3. TSH alone should suffice. How about if the symptom, what you're suspecting is hypothyroidism? Then if your suspicion for hypothyroidism is moderate to high, all you need is TSH and FT4 because this is not screening anymore. Okay? Generally, you don't need T3. Okay? If there's T3 thyrotoxicosis, generally there's no T3 hypothyroidism. So once a TSH FT4, that's enough. Okay. And when in the early phases, we said 6 weeks before starting thyroid hormone or titrating thyroid hormone dose on a patient, generally you have to wait 6 weeks, but you cannot wait for whatever reason. The patient is quite symptomatic. The patient need to undergo surgery. The TSH will take an urgent surgery that cannot wait months. So if it's less than 6 weeks since I titrated or started the thyroid hormone, one can request for FT4 alone, so that to tell you that it's already in the normal range and then you can proceed with the surgery. But to really know the fine dosing of thyroid hormone in somebody who's hypothyroid, really need to wait 6 weeks at least. And in those situations, you need to check both TSH and FT4. Okay, but once they are on a long stable dose, for example, many of my patients who are on thyroid hormone replacement for 2 3 years and they've been stable, then since TSH will be the first one to become abnormal, I don't want them to spend for the FT4. For as long as TSH is normal, then it tells me that their thyroid hormone dose is perfect. I don't need to change it. And the T4 won't help me too much anymore. Okay. But sometimes if there are um, situations whereby your TSH cannot be interpreted very properly, then a paired test once in a while to follow them. But people who are on thyroid, stable doses of thyroid hormone for a long time, we just follow the TSH. And in fact, you don't have to follow them too often. The TSH on every 6 to 12 months should be okay in somebody who's on stable dose of thyroid hormone for their hypothyroidism. How about if a situation, say, for example, somebody's losing weight, okay, and there are symptoms. So if your suspicion is low, just say irregular menstrual period or some heat intolerance, some palpitation, but no other symptoms, then TSH alone should be enough. But if they have constellation of symptoms that points to thyrotoxicosis, making your suspicion moderate or high, generally you have to request for all the three. Okay? Why? In the States, for example, they have this protocol. The laboratory is automatic. TSH will be run. If the TSH is abnormal, they will proceed to do FT4. And if the TSH is low, they will do both FT4 and FT3. they're able to do it because the result comes back really fast, and the algorithm of the laboratory actually does it. In the Philippines, they cannot run this algorithm because who's going to pay for the T4 and T3 unless the insurance company approves it, or the patient comes back and pay for it by the time the blood might be spoiled already. So therefore, generally the patient ends up getting a full panel. In the States, most of them are insured. That algorithm, automatic, the insurance company will pay for it. So there's no waiting period. The lab will just automatically run them. So, but I suggest, especially for patients whom you suspect to be hyperthyroid and they live in a far area, and it's really quite a discomfort and hassle for a patient to come back. Just if you're suspecting hyperthyroidism, just request for all three. And I said earlier, the TSH will be the last to become to go back to normal in the early treatment. So how to titrate methimazole? Generally, we follow FT3, FT4. Once you have one set of both normal FT4, FT3, then on next follow up, you can start checking their TSH to see whether you reach the correct amount of TSH. Remember, in the treatment of both hyper and hypothyroidism, your ultimate objective is to normalize TSH. And if they are on long-term stable dose of antithyroid, you can just follow TSH. And once in a while, you may want to follow FT3, FT4, but you can just follow TSH because as long as the TSH is normal, you know the patient is on the right dose. When are the other situations whereby you want to request for all three? In sick thyroid in patient in the ICU. Okay, generally if they're critically ill or very ill, even in the wards, you have to request for all three so that you can diagnose non-thyroidal illness during pregnancy. And also, if the patient had history of, let's say, radiation to the head or trauma to the head or surgery to the cellular area, whereby you suspect that the axis may not be intact, TSH is no longer reliable in those situations. So therefore, you have to request a whole panel. So these are generally how to save patients. And people who do not understand which one to test will generally tend to just say, run everything. They would even do the total T4 and total T3, all five of them, which is wrong. Okay, so it's like doing hepatitis profile during acute versus chronic. We have to pick which ones. Or people who don't understand will just write do everything, and I'll worry about it. So, but patient will end up spending a lot of money. And one needs to remember these drugs that can cause spurious thyroid tests. Okay, so meaning all this in patients, even euthyroid, you'll end up having abnormal thyroid function tests because of interference in the laboratory assay. So biotin can give you a picture of primary hyperthyroidism. So biotin is quite popular, right, for hair growth and nail strength, for example. It's just the patients are euthyroid, and you have to ask your patients on biotin to stop biotin for anywhere from 3 to 7 days so that it would not interfere with the thyroid assay. And other, for example, the anticonvulsants, carbamazepine and phenytoin, can give you a picture of central hypothyroidism, meaning low T4, low T3, the TSH is supposed to go up, it did not normal, so it makes you think of central hypothyroidism. While heparin, anticoagulants, and amiodarone can make you look like a picture of TSH producing adenoma, meaning all of them are high. And just remember these common drugs that can cause spurious thyroid function test reading, even though if your patient is euthyroid. So you have to correlate everything with the patient's condition and clinical, whether they are symptomatic or any physical signs like goiter, for example, or eye changes. If they don't have any of those, then one should doubt that uh, the drugs might be interfering with the test and the patient is actually euthyroid. So let's talk about some pearls, and if we have time, I'll run through some cases. So the diagnostic accuracy between total and free hormone is similar as long as you don't have drugs or conditions. Common ones are oral contraceptive, pregnancy, nephrotic syndrome, for example, uh, also causes because you're going to leak a lot of this binding protein. So those can affect the binding protein. So in those situations, you probably should run free hormones. You probably should be running free hormones rather than total for most cases, unless it's not available in your laboratory where you practice. TSH is the single best screening test. Remember the seesaw with the fulcrum not being in the middle? It causes tiny changes of T4 and T3 will cause a wide swing in TSH to the opposite direction. Okay? So unless you are suspecting pituitary disease or the patient is known to have pituitary disease, TSH is the single best screening test. And especially you want to save patient, if it's just a matter of low suspicion for thyroid dysfunction, TSH alone should be enough. Okay? However, paired T4 plus minus T3 with TSH is needed for moderate to high suspicion of thyroid dysfunction for correct interpretation to differentiate whether you're dealing with a primary thyroid problem or a pituitary problem. T3 is generally not needed unless in somebody who's in the hospital, you want to diagnose non-thyroidal illness, or in thyrotoxicosis, whereby there could be T3 toxicosis. So therefore, but the hypothyroidism, you don't need to request for T3 in great majority. It's a waste of money. But if the patient is thyrotoxic, T3 will help you interpret and not miss out on T3 toxicosis. Other, okay, other pearls. Paired tests that does not follow the CISO should be repeated in generally and correlated with patients clinically, and or if you don't worry about it, you refer the patient to an endocrinologist and let us worry about it. But great majority, it will follow the CISO, and if you can remember that much, and that's how you interpret thyroid function really easily in great majority. If they don't follow the CISO, uh, I think if an endocrinologist is around, you let us worry about it. Normal values might be different in older people. In fact, a higher TSH in older people in epidemiologic study had been associated with a longer lifespan. So generally, TSH mildly above, okay, in subclinical hypothyroidism. If they are 70 or higher, I don't even bother treating them. It's doing them good, okay? One needs to know that in elderly, in pregnant, the normal values are treated differently, okay? And both FT4 and FT3 are more useful than TSH in the earliest stages of treatment, whether it's hypothyroidism, okay, or hyperthyroidism, okay. But the case particularly is true for hyperthyroidism. Do not request for TSH unless your T4, T3, both of them, it's not just one, both of them have to be in the normal range before you start requesting TSH, because for as long as one of them is elevated, TSH will remain to be suppressed. And we already know that, so we don't need it. So that's to have mild diffuse goiter on routine physical examination. She is otherwise clinically euthyroid, meaning no symptoms at all. So, so in this case, it would be a screening test. All you have to do, just because of the goiter, what we know people with nodules or anatomic abnormality will have a higher risk of functional abnormality. It might be very subtle for them to feel it. So therefore, one needs to request for TSH as a screening test. So what if the TSH comes back normal? What is the next test? The correct answer is no further test. Okay? Because if you're not going to believe TSH in the first place, you should have requested for a pair test. So TSH came back normal, it's done. The patient is euthyroid. Because clinically, the patient is euthyroid, your suspicion is low, TSH. There's no indication that there's pituitary problem here. So TSH normal, the patient is normal, you're done. The patient is euthyroid. Okay? What if the TSH comes back elevated? Then one needs to proceed to do T4. So T4 available, that's the one available, you do T4. But we prefer to do FT4 because it's the one that causes the negative feedback. But if T4 is the only one available, go for T4. That's okay too. So TSH came back elevated, FT4 low. It follows the CISO, the diagnosis. It's a primary hypothyroidism, which is more than 95% of the cases of hypothyroidism. You just have to look for the cause, from thyroidectomy to radioactive iodine, Hashimoto's. Ask them about their diet. Okay, these are the four most common causes of primary hypothyroidism. How about so you started the patient on levothyroxine. So what is the best time to repeat thyroid function tests? We said the patient's really not symptomatic anyway, so at least 6 weeks. They're not in a hurry to find out. Okay, so sometimes we say less than 6 weeks, the patient needs to undergo a urgent surgery. The TSH will probably not be normal. Just follow the T4. But for most part, outpatient clinic, wait at least 6 weeks. Case number two, 20-year-old female complained of weight loss and palpitations. So symptomatically looks like thyrotoxicosis. She too has mild diffuse goiter and on routine physical examination. So is this screening? The answer is you need a paired test because the suspicion now for thyrotoxicosis is moderate to high, not mild. So to proper interpret whether you're dealing with a primary or a secondary thyrotoxicosis, then you need a paired test to see whether it's going CISO or not. So what if the TSH comes back low and T4 is high, FT4 is high? Very simple. The diagnosis here is thyrotoxicosis, primary one. And you look for, is it Graves' toxic adenoma? Is it uh, thyroiditis? Did they just deliver to a baby, what we call postpartum thyroiditis? Or are they on thyroid hormones from outside? Okay. And in patients who have endogenous thyrotoxicosis, uh, to differentiate Graves from thyroiditis, where in thyroiditis there's leakage, in Graves' disease, we said there's a preferential increase of T3, while in thyroiditis, there are more T4 that's going to be leaked out because T4 100% comes from the thyroid, and T3 only few are stored. 20% comes from the thyroid, and majority of your active T3 are from peripheral deiodination of T4. So getting an FT3 might help you differentiate which what's causing your thyrotoxicosis. Obviously, just to go back, if the patient is taking thyroid hormone from outside, you don't need a T3. It's going to be exogenous thyroid hormone are largely T4. Okay, so one need not request for a T3. So TSH low, FT4 is normal. What is your diagnosis? Subclinical hypothyroidism. Okay, with a question mark. And it says not so fast. You need to rule out T3 toxicosis. Remember, T3 is the more active hormone, and it by itself, in 5% of patients with Graves' disease, is capable of suppressing your TSH. So you might be dealing with T3 toxicosis. So if the FT3 is high, then your diagnosis is T3 toxicosis. On the other hand, if both T4 and T3 are normal with suppressed TSH, then you have mild or subclinical hyperthyroidism. Let's go to case three. A 30-year-old female complained of cold intolerance and constipation. She is now 4 weeks pregnant. She had a thyroidectomy for benign nodular goiter 3 years ago. Okay. In this case, thyroidectomy, and there's no indication the patient may have pituitary problem. So therefore, you need a paired test. Okay, TSH and FT4 to confirm that the patient is primary hypothyroid based on your suspicion. So TSH elevated, FT4 low. What is your diagnosis? Obviously, this is primary hypothyroidism. So treatment, thyroid hormone. Okay. TSH elevated, FT4 normal. In this case, you don't need T3. There's no T3 hypothyroidism. If there's T3 toxicosis, generally there's no T3 hypothyroidism. There are, but they're quite rare. Let's worry about it. But for most part, the patient has mild hypothyroidism. So let's go and talk about this 60-year-old male complained of cold intolerance and constipation. You know that what that means clinically. It's kind of hypothyroid. But the patient had radiation to the nasopharyngeal area for for cancer 10 years ago. Currently, patients on testosterone for low libido and hypogonadism. In this case, okay, so one suspect pwedeng natamaan yung kanyang pituitary during the radiation. So therefore, symptomatic or not, the patient needs a paired test. You cannot do TSH here, especially the patient is symptomatic. So you need a paired test. So TSH is normal, total T4 is low. So in this case, hindi na available in FT4, ang nagawa yung total T4. TSH normal, T4 low. Are we going to call this patient as having secondary hypothyroidism? Okay, kasi pag low T4, dapat mataas ang TSH. Pero again, not so fast. Okay, so remember, there are medications that can cause binding or carrier protein to go up or go down. In the case of testosterone, binding protein goes down. So your inactive portion might just go down, causing the total T4 to be low. Okay? Remember, it's the FT4 that's causing the negative feedback. So one needs to get a free T4 in this situation because androgen can lower your TBG. And for all you know, patient is euthyroid. So, but if the FT4 comes back low and TSH is normal, this is inappropriate. A low FT4 should have a very, very high. Remember, mild drop in T4 should swing the TSH in the opposite direction widely. Why would the TSH be normal? This is inappropriately normal. So one can diagnose secondary or central hypothyroidism. Okay? And TSH high with FT4 low, it's following the seesaw. This means the radiation did not affect the pituitary and the patient may karapatan siyang magkaroon ng primary hypothyroidism. Okay? Pwede pa rin siyang may Hashimoto's or iodine deficient. So, pag sumunod siya sa CISO, ang hypothyroidism niya ay primary versus yung kanina, low T4, normal TSH, inappropriate. Ang normal TSH in somebody with low T4 diagnosis will be central hypothyroidism. So for the last case, so you have a 40-year-old female with hypothyroidism rather, due to previous thyroidectomy for benign nodular goiter. She is now on 100 micrograms of levothyroxine, which is T4 per day. Then you request for thyroid function test, and the TSH comes back high with a low T4. So what will you do next with the 100 micrograms? Okay, low T4, the pituitary is still unhappy with the amount of circulating thyroid hormone. That's why it's attempting to stimulate a non-existing thyroid gland. So you have to do it for them. Okay, so what will you do? Increase the dosage because the pituitary is still unhappy. Okay, however, in any form of treatment, not so fast. You have to check whether the patient is taking it properly, the way you wrote it. Thyroid hormone is one of those medications that can be affected by other agents, especially for absorption. The instructions for taking T4 or thyroid hormone tablet is 30 to 60 minutes before breakfast on an empty stomach. Even coffee or milk would affect the absorption of thyroid hormone. And there are common medications that blocks the absorption of thyroid hormone, and this is quite important. Multivitamins that contains iron pill, calcium will bind up thyroid hormone in the intestine and making them inefficient or um, malabsorbed. So therefore, patients who are on thyroid hormone should be instructed that if they're going to take calcium, iron, multivitamins, and there are others, PPIs, also proton pump inhibitors, can block the absorption of thyroid hormone. So the patient says that they are taking it the way you instructed, and there are no drugs from your review of drugs that interferes with the absorption of thyroid hormone, then the correct answer is to increase the dose. If they are not compliant or there seems to be a drug that's blocking it, then do not touch a dose. For most Filipinos, even after thyroidectomy, the dose will be very close to 100 micrograms. So this is weight dependent dosage, but it's mostly close to 100 micrograms per day. Okay. So maintain same dose if the patient was non-compliant. The other thing is, okay, one last thing before I end this talk. You're gonna see us prescribing thyroid hormone on different doses per day. So huwag kayong magtaka. Unlike amlodipine, 5 milligrams is 5 milligrams every day, pretty much. Thyroid hormone, because of its long half-life, strict rule is you can give it all the tablets once a week, but we don't do it because there might be a peak that may make the patient symptomatic, or the patient might forget all 7 days dosage altogether. So that's why it's given every day. So to fine tune levothyroxine treatment, so I'm going off topic here in treatment of hypothyroidism, you need not give the same dose every day. In the state, can give the same dose every day because their preparation of levothyroxine is 12.5, 25, 37.5 increments of 12.5 all the way up to 150 micrograms. And they have 25 increments from 150 to 300. So they can give the same dose every day. In the Philippines, we only have 12.5, 25, 50, 100, and 150. So there are no in between doses. So how can you fine tune the patient's TSH if you have very little preparation? So what happens is if the patient is on 100 micrograms every day and you think they need 125 or 112, for example, and what I'll do is Monday to Saturday, they take one tablet of the 100, and every Sunday they can take 200. If you think that 100 every day is a little bit too much because TSH is somewhat suppressed, then the levothyroxine would then be taken Monday to Saturday. So huwag kayong magtaka na may araw na nag-skip or may araw na dodoble yung pasyente. This is normal, it can be done, and it's correct way to do it. Okay? So with that, I will end my talk. I think we have a few minutes still for Q&A.
Limited finances, what laboratory exam is best to request to have a fairly accurate diagnosis? And when is the proper time to refer the patient to a specialist?
So I think we talk about this. If their index of suspicion for thyroid dysfunction is mild, meaning there's only one single, goiter lang, pero wala silang symptoms. Or ang symptoms lang nila is abnormal menstrual period. There's no constellation or the checklist of a textbook description of hyperthyroidism or hypothyroidism. Then, para makatid yung pasyente, TSH lang. Kasi siya naman yung unang-unang maging abnormal. Tapos pag bumalik siya normal, tapos na yung kwento. Normal yung pasyente. And then kapag siya ay high or low, then you have to proceed to check their T4 to interpret it properly, whether it's a pituitary problem or a thyroid problem. So majority will follow the seesaw, okay? And anong the second question, Meg? And if it doesn't follow the seesaw, the negative feedback picture, then you cannot quite figure it out. It's the best time to refer it to an endocrinologist. So I'm sure, Meg, you've encountered this during COVID season. We really have patients who underwent a lot of thyroiditis. So much more than Graves' disease, they will have thyroiditis. So they have a goiter, sometimes even nodular. And I've seen a couple of, not more than a couple of patients, because of the nodularity from the thyroiditis, they were scheduled by a surgeon to undergo thyroidectomy. But it's a classic picture of thyroiditis. And I tell them, well, if I were you, I won't undergo surgery yet because oftentimes once the inflammation goes down, the nodule will shrink in size. And true enough, I've saved a few patients from undergoing surgery because the nodule will just disappear after a few weeks. So going back to the question of hypothyroidism, whether to treat or not, yes, most of these patients, after the leakage of the thyroid hormone, they'll have thyroiditis, so thyrotoxicosis transiently, and eventually many of them will become hypothyroid. So whether to wait for them to recover, and majority of the patients will go back to normal and recover, and whether in between to give them thyroid hormone is depending kung symptomatic sila o hindi. Pag alam mo ng thyroiditis siya, chances are mag-recover naman siya. So therefore, just follow them with maybe every 4 to 8 weeks of thyroid function tests. If they're not recovering, you probably should treat. If they're recovering, then you probably don't have to treat. But at the time that you found that they're hypothyroid, the most important question to ask is, or to consider whether you're going to treat or not, is, are they symptomatically hypothyroid? If they're sluggish, sleepy, gaining a lot of weight, cold intolerance, I'll probably treat until the thyroid gland is able to wake up and produce the thyroid hormone again.